Good morning, everyone. Welcome to Pediatric Grand Rounds. It's Dr. Permashore. Thank you for joining us online and in person at the Mill Mountain Conference Room. Quick announcement for all of our newer attendings. Please remember that you can sign up one time with your ABP number, and Grand Rounds, you can receive both your AMA Category 2 credits and maintenance of certification credits that are automatically uploaded to your ABP portfolio. So just please contact Megan, and that's a one-time sign up only, and then it makes it really easy for you for your cycles of, recertification. There we go. All right. Today's speaker is Dr. Violet Borowicz and Dr. Christi Stewart, speaking to us about effecting change in pediatric palliative care and pediatric hospice care. Dr. Borowicz is a pediatric hematology oncologist and pediatric palliative medicine physician here at Carilion since 2014. She completed her medical school at Drexel University College of Medicine, her residency at Nemours Alfred DuPont Hospital for Children, and her pediatric hematology oncology fellowship at Children's National Medical Center. She is the Associate Program Director for the Pediatric Residency Program here at VTC, as well as the Medical Director for Care Connection for Children. Dr. Stewart is the Medical Director of Palliative Care and Hospice, and she is also the Phase 3 Director at VTC SOM. Please join me in welcoming Drs. Borowicz and Stewart.
I may be winging Dr. Stewart's part a little bit. So we just wanted to kind of go over pediatric palliative care and all the things that my wonderful team has done to help me kind of grow pediatric palliative care here in the last couple of years. This is a Story People print that says there are lives I can imagine without children, but none of them have the same laughter and noise. So both of us don't have any financial disclosures. We're going to go through an overview of pediatric palliative care, review what we have done for pediatric palliative care here at Carilion, discuss how we can effectively communicate about pediatric palliative care, and then the steps for referral to me or to hospice. So what is pediatric palliative care? It is specialized medical care for any child living with a serious medical illness. It is appropriate at any age or any stage of serious illness, and it can be provided alongside curative treatment. So it's not an either or. It's really meant to be a part of the continuum of care. The focus is really on providing relief from symptoms and the stress of illness, and trying to improve the quality of life for both patients and their families, so parents and siblings as well. And then it's really based on the needs of the family, not on their prognosis. So pediatric palliative care addresses the needs of infants, children, and adolescents, and young adults and their families. We're trying to do treatments that relieve suffering across multiple realms: psychological, physical, social, practical, and spiritual. Trying to help facilitate informed decision-making, improve their quality of life and enjoyment of life, and then assist with ongoing coordination of care. With the American Academy of Pediatrics, these are the core commitments of pediatric palliative care and pediatric hospice care that's listed on their document. Integrated into the continuum of care, being Stewart is coming. She went to the wrong place. Being patient-centered and family engaged, respecting and partnering with patients and families, providing care across the spectrum, age spectrum, and lifespan, pursuing care that is high quality, readily accessible, and equitable. Improving care through research and quality improvement efforts, and ensuring that all clinicians can provide basic palliative care, and then consulting those who specialize in it in a timely manner. What comprises an effective pediatric palliative care team? It's an interdisciplinary team. Strong relationship between the medical team, the child, and the family with effective communication. Decision-making about ongoing medical treatment based on the goals of care for the child and family. And then managing symptoms due to underlying disease and ongoing medical treatment. And then preparing patients and families for the end of life as needed. What mature teams should include: physicians, nurses, social workers, case managers, spiritual care providers, bereavement specialists, and child life specialists. And then quality and safety, you need an adequate volume of dedicated staff trained in pediatric palliative care, and then with 24/7 consultation available. Granted, right now there is not, because I am one person and cannot be on call 24/7, but one day, maybe. So the benefits of pediatric palliative care: we have improved clinical outcomes, improved quality of life, increased enjoyable experiences that these kids can actually partake in things. We had one kid whose goal really was to get back to school, and that's all he wanted. So being able to manage symptoms so that he could go to school for however long he could stay in school was really important to him, and that's what we focused on. Trying to improve their patient and family satisfaction, so trying to manage the caregiver burden, and then symptom management too. I have a lot of kids that I have on gabapentin, for example, because they have visceral hyperalgesia. I have one kid, who I share with Dr. Cordell, who had fallen off the growth curve when mom had weaned him off of gabapentin. And for a year I hadn't seen them, and then she comes back to me and we realized that he needed his gabapentin because he was having so much stomach issues. And then reduced healthcare costs. There's reduced hospital and ED utilization, and there is reduced visits when they're having this quality of life managed, so they're not having to go to the ER to manage their symptoms as much. And families don't want to be in the hospital. They want to be home. So a big thing is how to introduce pediatric palliative care. Identifying the fear. One big thing is acknowledging that I'm not hospice, and I have one family who, even though the mom is a social worker, even though I have said repeatedly what I do, I walked in because I had a hematology consult for her, and she goes, "Go away, I don't need hospice." That was the first statement to me, and I was like, first of all, I'm here because of your CDC, not for palliative care. But even though I've had that conversation with her, she still associates me with hospice. And it's important to acknowledge that it's not just for end of life, and it's why getting pediatric palliative care involved earlier is important, because otherwise they do associate us with just end of life, which is not really what I should be there for. Providing reassurance, you as the primary care or primary physician, primary team, you're still coordinating care. My role is just to be an extra layer of support. And you can still get concurrent care. So getting palliative care does not take away all of the treatments that they're receiving. Normalizing it is helpful. So asking the team to participate, because any patient who has a serious illness, and then targeting what's important to the family. Helping with symptoms, managing stress, improving quality of life, focusing on those things to be able to help families understand what pediatric palliative care is. This is where Dr. Stewart would start, so I'm going to do the best I can. So one thing with hospice, all of hospice is palliative, but not all of palliative is hospice. Hospice is just a component of what palliative care is. So over 8,000 children and young adults receive hospice services annually. About 70% of parents voice preference for their child to die at home. Only 15 to 30% of children actually do die at home. Pediatric palliative care, hospice care, can begin in the womb with life-threatening congenital conditions. I do actually do consults with MFM when they have lethal fetal conditions. MFM does send families to me so we can start forming their birth plan and what they want for end-of-life care after their child is born. So I'm actually already doing those consults with MFM. We can extend it to young adults with chronic health conditions, especially because it's not uncommon for us to be taking care of young adults with chronic conditions. So the things that are most commonly referred to pediatric hospice, oncology, genetics, neurodegenerative, neuromuscular, cardiovascular are probably the top 17, 15, 20% that is referred. The Patient Protection and Affordable Care Act that was passed in 2010 does allow for concurrent care even with hospice for pediatrics. So children who have life-limiting illnesses, so there's still a 6-month prognosis must still be met, but they can still receive curative treatments and hospice care at the same time. And we've had kids that are on hospice for several years, so you have to be 51% sure that they would pass within 6 months, but we can renew that. So we do have kids who have stayed on hospice for a lot longer, even with the concurrent cares. Concurrent care therapies include therapies, medications, equipment related to the serious illness or serious health condition. You do not need a DNR to receive hospice services. Medicaid and CHIP are the most common payers. Hospice payment by private insurance is similar to Medicaid. It's a per diem, so it's a bundled service. They have add-ons and level of care rates. Each insurer has their own payment structure. Hospice care covers all visits and services, including medications, supplies, and equipment related to the hospice diagnosis. And then patients and families who do receive pediatric hospice care actually do talk about having improved quality of life, decreased patient costs, decreased parental stress. Their ability to be able to call the hospice nurse to help manage symptoms and not have to run to the ER or try to get a hold of their primary care doctor is huge too, because hospice is available 24/7 and they can have someone respond to them much more quickly sometimes in terms of whether or not they actually need to go to the ER and what they need to do and how to manage some symptoms at home. They have medications available at home and what medications may be more beneficial for a certain symptom versus others. All right, so what we have done at Carilion. In 2019, we started with trying to develop hospice pediatric order sets. I had received an order set to sign off on for a 4-month-old that I had put on hospice, and it had listed all of the adult orders. It was 650 milligrams of Tylenol and 400 milligrams of ibuprofen and I was like, whoa. And so I reached out to Sharon, and Sharon and I, we started meeting to create order sets that would actually be beneficial, and we have them weight-based and age-based so that there are now specific pediatric order sets with Carilion Hospice. And then there was also a REDCap needs assessment survey that was done of the Carilion Clinic Hospice nurses to help improve their education for pediatric patients. In 2020, there were pediatric simulations for hospice nurses and ancillary staff. And then in 2022, we launched a 12-month pediatric palliative care educational program that was underwritten by HR and involved over 20 interprofessional clinicians. We actually had a group come in from the PANDA team. They were actually, it was a nurse practitioner that I had trained with at DC Children's. She was a neuro-onc nurse practitioner before she switched fully to pediatric palliative care. But they came in and helped provide us some additional education to improve our entire group's education for pediatric palliative care. In 2023, it ended the year-long educational initiative and then launched a multi-pronged approach to enhancing our pediatric palliative care. So our goals have been to provide educational resources, enhance our bereavement support, and then offer compassion care to staff. So we do have a hub within Carilion, inside Carilion. It's updated with information, LNEC, Vital Talk, lots of stuff in there to help read and advance your own education in this. We also, thanks to help of Sarah, reinitiated our memorial service that had been on hold since 2020 because of the pandemic. And so we restarted it on June 8th, and we are planning to start do another one this year in June as well. We did it on Mill Mountain, invited all of the families who had lost children within Carilion Children's in the last 5 years. I think we went back to 2019. And we had a very good turnout. And there were a lot of activities, there were arts and crafts, people from the, what's the program?
Healing Arts.
Healing Arts. The Healing Arts, thank you. The Healing Arts program was there. They were able to, they had flowers that were donated from George's floral, right? They made a butterfly mandala in the grass. They made wind chimes. They did a lot of activities too. That was a lot, very healing and therapeutic. And we had several families ask us if they would still be able to be invited again next year. So I think a lot of families appreciated it. And we do want you guys as faculty and staff coming too, because I know families appreciate seeing you guys there as well. And then we've also started these pediatric palliative care mobile town halls. So far, we've only done them at RMH, or you've done them here now? But we are doing these mobile town halls to help provide support to staff too, because we know how much of a burden this is for us as well as caregivers. And so trying to be able to support us as staff going through this as well. I'm going to take over the advanced care plan.
Forgive my tardiness. I have no excuse except the definition of delirium, which is waxing and waning of attention and cognitive status. As part of the initiative that we've done with the PANDA program, we wanted to kind of bring light and focus to the concept of advanced care planning, which usually is a term reserved for adults living with chronic serious illness or terminal illness, but the idea is advanced care planning is really for everyone, and especially important, I think, when you're working with the complex psychosocial, spiritual, and family dynamics that is caring for children living with serious illness or the threat thereof. So, what advanced care planning is not, maybe we'll start there, it is not a document. That's an advanced directive, and that's an entirely separate conversation and definition. It is not a one and done conversation. What I have discussed with my husband about my wishes and preferences throughout my healthcare in this point will differ from where it was 20 years ago, will differ from what it is 20 years from now, God willing. But it is meant to be a fluid, changing, dynamic conversation. It is not irrevocable. What we decided we wanted on a document 15 years ago might very much change as our lives change through the years. It's not paternalistic. It is not your physician telling you what the right thing to do is, or vice versa. It is not the patient handing a list of demands to their physician. And it is not only discussed when death is imminent. In fact, I would argue when death is imminent is the least valuable place to discuss advanced care planning, and yet we often wait until that period of time. It is not a script, although the reverse side of that is that scripting can really help. Certain scripts have been developed to guide conversations that can make the conversations more meaningful and cover more points and identity factors. And the other thing it does not do is compromise hope. Right, so I have a lot of people in my world in palliative medicine say they're not ready for you, they're not ready for this conversation. When multiple studies done over a variety of patient ages, including children, actually show that advanced care planning conversations with their health care team reduces depression and anxiety around their health care up to 12 weeks out from the conversation. So these are long-lasting results. This is the whole idea. We don't want to tell them bad news. We don't want them to give up. We don't want them to lose hope. Advanced care planning conversations actually empower patients and families to do otherwise. They almost have the opposite effect of what sometimes we intend. This is a process. It is a series of conversations that is meant to occur over time in a variety of healthcare settings. The idea behind advanced care planning is not what do you want or what don't you want out of this laundry list of healthcare treatments we have to offer you. It is talking about what is most important to patients and their families. So a lot of times I say, tell me about what's important. And my families will say, I want to live. Okay, tell me what's important. I want chemotherapy. No, that's a plan. Tell me what's important. Why do you want to live? What are you hoping for from chemotherapy? What benefits are you looking for? What values are we trying to uphold and enhance? People don't want chemotherapy. I don't walk into Walmart and offer my chemotherapy package. Chemotherapy is a means to an end. Tell me what the end is. Tell me what the hope is. Tell me why we're fighting. Tell me what we're doing this for, right? It's verbal, most importantly, but it's important that we write components of this down, of course, as well. And it is challenging. I'm not going to pretend any otherwise, especially in the context of children, because you're not just working with an individual, you're working with a whole psychosocial team and pattern and family dynamics and finances and fears and paternalism and maternalism, and it does get complex. But the age even more so enhances the importance, because the complexity means it's that much more valuable that we go to seek these pieces of information out. The idea behind advanced care planning is not a physician telling a patient or a patient or family telling a physician. It is the true meaning of shared decision-making. Patient/family, tell me what's important. Tell me what we're fighting for. Tell me what the goal is. Physician, let me help you develop a plan that meets your values at its full and foremost foundation. So that's the idea. And then these conversations guide care through the entire trajectory of the illness. So that meeting someone in the outpatient clinic and saying, okay, this is what you were hoping for from your child. You wanted to see their 10th birthday. And then we get to the 11th birthday and we start talking about how that dynamic changed and what are we hoping for now in this place. And if they go to the hospital, we say, remember the goal? Remember the goal that we set together and what was important that we discussed together? Let's talk about how that goal moves backwards into your healthcare. So it's really important. Words matter. Words matter. Poor Dr. Arthur, who's had to do our fellowship with us, has heard this over and over again. Tweak the word. The word matters. You have no idea how much that tiny little word changes the whole dynamic of the situation. Attitudes matter. If we walk into these conversations with fear and doubt and trepidation, our patients and families have no choice but to feel that within us. I love, there's a really great blogger called How to Train Your Doctor. He's a palliative doctor. And he has a whole series about what happened if other healthcare fields were stigmatized and talk about like palliative. And the guy goes in and he's like, we have something maybe that I think it could be helpful. It's called palliative care and maybe, okay, no, I can tell you're just not ready. You're just not ready. And we never talk about other specialties with that. You would never go into a room and say, we have this thing called gastroenterology, and maybe we, your chronic GI. No, okay, not ready. But the more these attitudes and these environments that we approach our patient and family with, if we're not comfortable, how can they be, right? And I teach medical students, I say the more you normalize the difficult conversation, the more normal it becomes. You walk in saying, I have to take a sexual history and I know this is uncomfortable. The only person really uncomfortable in that is you. You're just projecting that onto that family and now they're uncomfortable with you. So it is important to normalize it. What I usually say is this is a script. I run through this with every one of my patients. I'm literally going to read the script off the page and we're going to walk through these questions together. Ask permission, because if they're feeling fear and anxiety in moments of crisis in the emergency department, not always the best time to say, tell me about what's important to you. And don't forget to respond to emotion, and we'll do a little bit of emotional work in the next couple of slides, okay? Every single one of my patients, I like to sit down at this opportunity in this safe space where everything is called, and I like to talk about what we may face in the future so we know how to take the best care of you possible. Is that okay? I feel like this isn't the place we're hoping for. Can we talk a little bit more about things that are important to you in this space? Emotions. I think we get scared of our own emotions as much as anyone else's. I had the wonderful privilege, and I throw her under the bus and she knows I do this in every lecture. I had the wonderful privilege of training a trauma surgeon, Dr. Katie Bauer, who is a wonderful individual. And when I told her about emotional empathy and emotional intelligence and the importance, she immediately got paper and said, is there a book for this? And then as we started to coach through her fellowship, she would go, yeah, the emotions are there, but they're such a time suck. So, and she knows I bring her up at almost every lecture I give, so she's given me full permission to do so. Good communication takes time. Being in a patient with emotional space takes time. Bad communication and not addressing that emotional state will take you infinitely more time in the long run. I promise you that. People say, I'm just not an empathic person. Look, I am not a hugger. I don't like to be touched. I don't have feelings, I'm aware. So I can get, but I fake it really, really well. And this is how I do it, okay? When I first heard about nurse statements, I went, this is the silliest, most condescending thing I have ever heard in my whole life. This feels like everything I need to know I learned in kindergarten level of condescension. And one of my partners said, just give it a whirl. What all you got to lose? You have nothing else to give these people in this emotional space. And I went, okay, well, can't argue that. And so I started to use them. The level of impact, acknowledging people as emotional beings and being willing to sit with them and pause with them in that emotional space does for rapport. Cannot be underrated. I mean, it is the most intense way I know to help families bond into these conversations. One is naming the emotion. I know this is scary. You are really frustrated with everything that's been going on at this point. I can sense how angry you are to be in this place that you didn't want to be. And they immediately go, yes. All we did was name the elephant. And it brings a sense of peace and belonging and allows people to feel seen. Understand statements, which oddly enough, never say, I understand what you're going through, because you never will. Even if you've gone through the exact same thing, you do not understand their perspective on the situation. So we say, I can only imagine. I can only imagine what you're going through. Wow, this is so hard. This is so difficult. It's just bringing it into the space of, yeah, things here are tough. Respect statements are my favorite way to deal with anger. When I have a really angry mom or dad coming at me, you are working so hard to advocate for your child. Even if they really, really want to yell at me, they can't quite figure out a way to yell at me. Yeah, I do really love I'm so mad that I can't be mad. Support statements, we're gonna walk this together. I'm gonna follow up with you. We're gonna pull the whole team together. We're gonna be talking about this. It just gives that sense of, it's okay, I'm not alone. And explore statements when I met with that stony silence, that thin veneer, if I'm trying so hard to hold it all together. Can you tell me a little bit about what's on your heart? Can you tell me a little bit about what you're thinking in this space? And silence, a lot of pause. Sometimes we just sit in the space. Silence tends to make the person on the other side of the table more uncomfortable than me. And so they usually start talking. We just hold that silence for a little bit. Can you tell me a little bit more about what you're thinking in this place? And they go, no, I can't. I'm just so angry. Yeah, there it is. So I liked this. This was something that the Panda team that came to talk to us said. The same letters used to spell listen are in silent. So it allows people the space to feel heard. People are really not used to this in healthcare. They're not used to being acknowledged as emotional beings. They're not used to a provider wanting to hold emotional space. It takes them completely off guard. I have gotten a lot of, you are the only doctor who's ever listened to me. And I actually never believed that to be true. I do not think I'm the only doctor that's ever listened to them. But I think I'm the only doctor that maybe has acknowledged that emotional space and place that they hold and how important it is in their healthcare journey. So, the role of the families in advanced care planning, especially when you're looking in pediatric cases. They're the only ones who can speak about, I can't project what's important to Dr. Borowitz's family onto Dr. Borowicz any more than she can project what's important to me, right? I need to understand what you're thinking. I need to understand what's important to you. I know what I think should be important to you, but that doesn't mean it actually is important to you. And I think that's sometimes where the frustration comes in healthcare, is we say, this is what they should be focusing on right now. Why aren't they bringing their child to the appointments, and why aren't they doing the medications? And mom's there going, I don't know how I'm going to pay my bills. Right? So it's that idea of we can't project what we feel should be important into their space. They have to project it into us. And that develops shared understanding, which leads to shared decision-making, and it allows space for questions. I just had a patient yesterday, and sitting in the emotional space, she went, we depend on his Social Security check to pay the rent. And I went, when does the Social Security check come out? She's like, the first of the month. Are we waiting to the first of the month to make decisions? Because you don't know how you're going to keep your kids housed. She's like, is it wrong? I'm like, it's not wrong, but it's important we know, right? It changes the whole dynamic of that conversation. Do I think that we need to keep this person on this level of life support to the first? No, but is she worried about how she's going to keep a roof over her kid's head? Is that the thing that's driving her decision-making? It's important that I know that, right? If we don't even acknowledge it, we can't have that space for questions and wondering. So what do you know? What have you been told? What's been shared with you? This is how we open every palliative conversation, no matter what. No matter if I was in the room yesterday and I'm coming back in the room today, I start with, where are we? What are you thinking? What's been shared? What have you been told? They need to have the power over the information that they've been given and that they're capable of receiving. What are you hoping for? That is our number one question. What are you hoping for? I want to live. Cool. What else? What else? What else? What are you hoping for? What are we doing this for? What's most important? What are you worried about? Is it okay if I share with you a little bit about what my understanding of your situation is so we can come to the same place? But that only comes after they've had the opportunity to talk. Because it changes how I might share that information and what that dialogue we're going to engage in. It's a dialogue, right? In healthcare, we've been taught to monologue like champions. When you're really talking about advanced care planning, this is how we engage in dialogue. And dialogue is giving the power back to the patient and their family and opening that conversation. As far as the role of the child, I get a lot of parents going, well, they shouldn't even hear or participate. And I don't know that that's always fair. I do believe in safe spaces, and I do believe that children and parents may feel safer expressing fears and worries without the other one present in the room. So it might be important to give them both separate space so they can ask hard questions that they don't want the other person to hear. It's important that we give them both that space to some extent. How can sense the emotions, right? They don't know, and the parents come in and they're all red and puffy. I promise you, I have a 15-year-old and he's about as emotionally obtuse as I am, but he can tell the minute I walk in the door whether I've had a good day or a bad day. They want to be heard. Not just the children, everyone. Everyone wants to be heard, right? And the frustration comes when they're not feeling they're being heard. And the misunderstanding comes when they feel they're not being heard. If only thing they see is the emotion and the children aren't given any context, imagine how horribly scary that is. What if you were sitting in a hospital room and you had no idea what was going on, but everyone around you looked angry, frustrated, had tight faces and puffy eyes? I take care of patients who are dying all the time. You know how most of them figure it out? When their whole family comes to bedside and they go, oh, am I dying? And that might be the first time the family's allowed that piece of information to get to them. But it's kind of obvious. You called in my cousin from Topeka, right? Rather than making them fear the giant unknown and ghost, let's call it out and talk about it. It becomes much, much less scary when we shine the light on it. Silence can be mistaken. There are a lot of assumptions that are made in places of silence. So just be really careful with that. Truth-telling builds trust. How many times do we see that you lied to me? Picture, we didn't lie. We gently tried to omit, but they don't see it as that. You do have to be careful about developmental appropriateness, of course. This needs to be taken into account, whether you're working with toddlers or children or preteens or teens. Utilize your psychosocial colleagues. Utilize your great pediatrician partners about how to deliver developmentally appropriate information in a way that can be clearly understood. And please, please respect cultural and religious values and preferences. It's not, I've had a lot of families say, no, I'm in the geriatric world in all fairness, no, mom can't make decisions. She doesn't get information, it all comes through me because I'm the eldest son and this is how our culture works. And all I do is confirm with the patient, hey, is this how you want information? Do you want your son to just get all the information, make decisions? You'd be amazed how many people are like, yep, that's how I want it. Okay. So my usual rule when families say, are we going to talk to them? I say, we have to answer their questions clearly and honestly. We will never lie to them. But we also don't have to force information down their throat that they're not ready to see, hear, or process. Right? We have to find that balance in that place. Any questions to this point? The complex dynamic. This is my whole fellowship in a singular presentation. I like it. So when should we start talking about this? If they have any type of a terminal medical condition that will end their life at some point, we need to start talking about this. They say with 6 to 12 months, and I get that, but I would say even before that, let's start talking about this. The thing I generally see is We are horrible at the 6 to 12 month game as providers. We really are bad at it. I mean, really bad. Physicians have a tendency to overestimate their patient's life expectancy by a factor of 3. So if you say, I think it's going to be 3 months, it's really probably only a month. And the closer you are to your patient, the worse you are at doing this. And I've fallen into that trap many, many, many times. I remember a nurse grabbing me once in my nursing home and saying, go in there and do what you have to do. And I'm like, no, she's going to be okay. We're going to give her some antibiotics. And she's like, oh, and your patient. And put your doctor hat on for once. So it's okay to understand that we're going to have biases in these places. And it's okay that we hold ourselves accountable as a healthcare community to doing the right thing for our patients and families. If the word hospice is entering into your brain at any point in time, if you're like, I wonder if hospice, the next thing out of your mouth is, no. If the word hospice came into your thought bubble, you need to be having a conversation. If there's any type of life-threatening event, we need to be having the conversation. They're not ready, we just need to start the discussion. Anytime you're thinking about a high-risk therapy, a transplant, a VAD, you need to be having the conversation. Anytime you're just not sure, you need to be having the conversation. Anytime you're taking care of a patient with chronic illness, you need to be having the conversation. Okay? The graph of palliative to curative goes like this. But that doesn't mean that it's a block. It's not curative, palliative. It's a spectrum. And there are a lot of studies that show that the conversations are most effective when started 6 to 8 weeks after the diagnosis of anything, of any chronic disease, diabetes, heart disease, genetic abnormalities. Start those in utero. I mean, what are you waiting for? Are you waiting for the crisis? Right? This is a nice quote from Mr. Rogers that I will allow you all to slide through. This is that when we talk about it, it becomes less overwhelming and less scary. Anything that's human is mentionable. Anything that's mentionable is manageable. Anyone else a Lord of the Rings fan? Cool. You remember the first Lord of the Rings movies? Remember how scary the Nazgul were? The suckers were terrifying. Remember in the third movie how intensely unscary they were? Because we'd seen them so often. Right? It's that seeing and talking and understanding that helps to eliminate the fear. Do you want to take this one?
So referrals, inpatient and outpatient. I also do peds pain management that is a separate referral. The adult group who covers my palliative will not do the peds pain management, just as a blanket statement. There is, via Perfect Serve, there is a pediatric palliative care CRMH group, and services are available Monday through Friday, 8 to 5. If I'm on call for HEMONC, I will be on call for palliative care as well. That is the only time that it is 24/7 is when I'm also on call for HEMONC. Outpatient, there is a referral, an ambulatory referral order that you can put in, but it's helpful if you send me an Epic in basket just so I can let my secretaries know, because sometimes the referral doesn't drop appropriately, and so we miss them for a little bit because it just isn't dropping into their queue. So if you just send me an Epic in basket saying, hey, I put this referral in, it helps just so we can keep track of it and make sure that we're getting kids in as soon as we can, because I will pretty much see them as soon as possible. And I do try to coordinate a lot of the outpatient visits with other subspecialty visits that they may already have, just to make it easier on travel for families. And even with MFM, like if they're coming up for an OB appointment or MFM, then I'll have a concurrent appointment with them. And then I also do e-consults now as well. So if there's any questions about symptom management or barriers to the family actually coming to meet with me in my office, then you can also send me an e-consult. And then for hospice, there are Epic referrals. You can call the intake center or fax the intake center as well. And then we can do this consult to inpatient or consult to hospice from an inpatient standpoint or an outpatient standpoint as well. Usually when it's an inpatient, it does go through me typically first, but it doesn't have to on the outpatient side. I don't mind doing it, but it doesn't have to. The other thing we wanted to just bring up briefly, so hospice, what is GIP stand for?
General inpatient.
Actually, yeah, the general inpatient. So we, Dr. Stewart worked very hard on the adult side to work on converting patients to hospice inpatient on the adult side, and we are now moving to introducing that to the pediatric side. We've done it for one patient, kind of on a trial run without having done it, and we did, and it went very
really well.
Yeah. We're trying to help provide hospice services to pediatric patients who are in the hospital who may not be able to go home. So consulting me to initiate the discussions, determine the appropriateness for GIP level of care. We are still able to do concurrent care even on inpatient side for pediatrics. Because of the way inpatient hospice works for the adult side, the primary team will still be placing the orders with the assistance from palliative care or hospice. If these kids get converted to a GIP, you discharge them and then readmit them under the hospice.
So we have a whole process and checklists.
There's lots of paperwork that Dr. Stewart knows about that
yes.
I know nothing about.
But you wouldn't have to do, we'll take care of most of the paperwork. I'm just saying we have a process, we have a guide, we have support, we have resources, yes.
When you do that transfer in terms of our notes and billing, is it still the same as we would?
Exactly the same.
Service?
The only thing you get to do is bill a little bit extra for a discharge and a new HMP.
Any questions about the?
But that would not be any additional cost to the family. I do want that very clearly heard. The family does not bear the cost of any of the resources or paperwork. And it does allow an extra and additional level of support for that patient and family towards the end of their life journey. So things like music therapy and, extra social worker support and bereavement services, and it's a nice service that really focuses on the psychosocial spiritual health that's going on for that family, enhancing and working alongside everything else that the amazing interprofessional teams have done to support the patient and family to that side. So it is not a replacement or a substitution, it is an enhancement.
Any questions about anything that we've talked about? Comments? All right. Did put in some MOC questions for those who want to get MOC. But pediatric patients are able to receive concurrent care. True or false?
I just want to point out the blessing that is that they don't have to choose. That you don't have to say you don't have to reject whether or not they're ready or whether or not this is appropriate timing. You can just introduce it and they can still get everything they are hoping for from their medical care. We don't have the same blessings on the adult side. So.
And it does make a huge difference. When I first started here in 2014, I was consulted on a 15-year-old with Duchenne's muscular dystrophy because he was nearing his end of life. And the family immediately, they would not let me meet him because they said, you're just going to walk in there and tell him he's dying. And I was like, well, I would never do that, but they just could not accept me into the room. And it was bad enough that even though I got hospice set up for them, they even told hospice that they wanted them to hide the word hospice on their badges and that they didn't want the 15-year-old who was very well aware of what was happening to know what was going on. And it was a very difficult conversation because they didn't know me, because it was just introduced right at the very end. Whereas I had another child who I met in the NICU at birth, and for 9 months, I had seen them almost every month in my office after she got discharged. And when she was 9 months old, she came in very sick. And all I did was go up to the PICU. I sat next to Mom, who was 17. I put my arm around her, and she said, I can't keep doing this to her. And without me saying a word, Mom made the decision to transition to comfort care because she realized how bad it was. But because I had that relationship with that mom, I didn't have to say a word. I just had to sit there and let her say it. So it is impactful for me to get involved much earlier to help these families with this decision-making as well. Question 2, pediatric palliative care aims to relieve suffering across multiple realms, improve quality of life, facilitate informed decision-making, assist with ongoing coordination of care, all of the above.
You made it too easy.
I know. All of the above, yes. I did make them easy.
One of the mantras we say about palliative is that the only thing you do is wait until the end of life. The only thing we're ever going to be is an end of life team. And we can do so much more.
Yes.
If the only time you called in a cardiologist was when somebody needed a heart catheterization, the only thing a cardiologist would do is heart cath. And they can do so much more. It's no different. So.
And I also want to give a shout out to our amazing team who has made this happen.
This is a lot. This is a labor of
Patrick
love.
and Sharon and Andrew and Sarah and everybody who's not here as well.
And if you're not sure, pick up the phone and call us.
Yes.
We're always happy to bounce ideas off. Well, I don't love doing pediatric pain management. I have, because I take care of hospice babies. I'm happy to bounce ideas off of anyone and say, are there aspects to this that we're not addressing or thinking of? That's the beauty of a collaborative interprofessional team, is we can draw off of each other's expertise, and what an awesome place to work that we can do that.
Any more questions? Thank you so much.